Excellent. Okay, good.
Huh.
Well, we're thrilled to have you all with us. Josh, the time is yours.
Awesome. Let's take it away. I've asked Michael Cheriton if he could kick us off with an opening prayer. Michael, will you do that for us?
Yep, absolutely. Father in heaven, we are grateful for the opportunity in which we have to meet together this evening. We're grateful for our respective positions and callings that allow us to be able to serve thy children, especially the most vulnerable. We pray that we might be guided in how we can go about doing good and the art of healing, and to be able to just help those who might have big burdens. And we're grateful for what we do have and for the guidance in which we have been provided. And we pray that this evening we might have a good discussion and just enlighten one another. And we say this in the name of Jesus Christ. Amen.
Amen.
Thank you, Michael. So, everyone, I want to thank you all for participating tonight and taking time away from your family and your friends. Healthcare is ever changing and it's getting increasingly chaotic, and us as the leadership of that, being friends and former participants of BYU, we have a great responsibility to be, leading the charge and taking charge in healthcare. And so I'm very grateful for all of you participating tonight, and not only hearing from Brenton this evening, but also being participants in the discussion, and then going forward and really lending your voice to what is a chaotic sphere. So thank you so much. Let me pass it back over to Britt as he kind of gives us a quick update in what is BYU healthcare leadership, and then I will give a quick overview of our speaker tonight. Britt.
Thank you. Thrilled to be with you. I'm Britt Barrett. I have been a hospital president for 20 plus years. I retired and joined SMU, then UT Dallas, and about 2 years ago, 2.5 years ago, I joined the faculty of BYU, and we have been teaching a class in healthcare leadership, a couple of classes. I'll share that with you in a moment, but we're thrilled that I could co-chair this with Josh. We want to build networks. We want to extend our network and relationships with the students and the alumni. So let me share with you kind of what's going on at the Y. And here we are. I'm going to go right here. There it is right there. And I'm going to go. Our theme is transforming healthcare through Christ-like leadership. The secular world might call that transformational leadership. We just say, how would Christ lead in an organization? He'd bring together a team. He'd have all sorts of skill sets. He'd espouse values and create a vision. So that's what we're helping these kids understand. The response from the students has been overwhelmingly positive. You may not have met Bill Taylor, but Bill years ago had a sabbatical or a 1 year with Intermountain Healthcare, saw healthcare up front. He's an accountant and thought, I'm going to support this. So he was the lead back in 2016. That's not to say that we didn't do a lot of things in the past. We had an executive lecture series and we were dabbling here and there, but Bill took off and he said, let's start teaching some classes. What you see in front of you in the blue line are non-Marriott School students enrolled in healthcare classes. The green line are Marriott Schools students. In 2022, I joined the faculty and the minor was approved by the Brigham Young. And you could see it just took off. So we teach a class, Intro to Healthcare Management. We teach a class on value-based care. We teach a class on finance. Actually, Dave Clark from Sutter Health teaches that class. We are introducing this fall a class on regulatory and bioethics. We have an executive lecture class. We have guests come once a week on a Tuesday. For the fall, we have 130 students enrolled in that class. So it's been exciting to see. We have a class on research, and we're looking at a class on the future creating bioinformatics. This fall semester, we have over 300 students enrolled in one of those classes. So there's obviously tremendous need. All of us recognize, and as mentioned in the prayer, thank you, Michael, This is purpose driven. This is meaningful. This is an opportunity to serve in a professional way. The announcement of the medical school didn't hurt either. The place has exploded. We have been notified that it will be on the campus, or it'll be located where the Provo High School currently is. And so they're planning to demolish a portion of it, build out some of the classrooms and build, and then demolish the remainder of that footprint. That will be open in September of 27. So they're sprinting really hard to get that approved. And we're working with them hand in hand. Bill's on a couple of committees to orchestrate what the curriculum looks like, how we network with alumni, those kind of things. So that's a quick update of what's going on at BYU. Here's another slide that, affirms this. So the classes are very well received. And initiatives like we have tonight, I want to thank Lisa Stevenson and her team, Matt and the rest. They do all the behind the scenes work, and we think it's value added. We want to network, introduce you to students, open doors for jobs. I think we all would agree that there was a time when we came out of school, we didn't even know what Medicare, Medicaid was, right? We were just completely clueless. And wouldn't it have been great? And I think many of us had mentors. Well, we like to solidify that and to open doors. And so that's the intent of this evening, and then also some education. So, Josh, I'll kick it back to you unless anyone has any questions, or we can discuss at the back end of this on what's going on at BYU. There is a conference coming up. And Lisa, if you can post that in the chat, there's a conference coming up October 3rd. That's at BYU. The theme is transforming healthcare through Christ-like leadership. It caps at 400, so you need to get in there fast and register and then invite others. We've sold out for the last 3 years. The year before that, it was online with COVID. Mark Ott, who's the new dean of the medical school, will be keynoting. We've got 3 CFOs, CFO of Integris, CFO of Intermountain, CFO of Corwell, that are all going to come and speak. They got a workshop. We got a couple doctors from Integris. They're going to come and talk about, one from Integris in Oklahoma City, one from Intermountain, going to talk about transforming healthcare and the experience for physicians. We're going to have a program on evaluating technology, transformative technology. So I think it's going to be a good program. The classes are intended to be illuminating, right? But we also, at the end of the seminar, the workshops, we will have a kind of a mixer, and we'll invite students to that. And our intent is to introduce you to students, and then also help them understand how to, remember those cocktail parties we all have to go to, and we have to say hello. We want to teach them how that's done, and also create doors to open for them for the future. So that's kind of what's going on here at BYU. It's a great time to be a Cougar, and if it weren't for the football team's quarterback, I think we'd be thrilled with the football season. But basketball season, we're going to rock the house. So that's it, Josh.
Thank you, Britt. So I'm very happy and proud to announce our speaker for the night. His name is Brenton Hill. He is the head of operations and general counsel at the Coalition for Health AI, healthcare's leading nonprofit thought partner organization dedicated to providing guidelines for the responsible use of AI in healthcare. He is trained as an attorney and a healthcare administrator. Brenton approaches his work from a risk-informed and operationally feasible perspective, which helps CHAI move with agility to accomplish its mission and best serve its members. Prior to his role at CHAI, Brenton served as the regulatory strategy and compliance manager for Mayo Clinic platform, assisting in identifying its approach to emerging AI regulation and risk mitigation strategies. As part of his role, he served as a member of Mayo Clinic's SAMD review board, which provides governance for AI models being implemented at Mayo Clinic. Additionally, he served as Mayo Clinic's first legally trained administrative fellow. After his first year in the fellowship program doing traditional hospital operations, Brenton pivoted and spent the next year exclusively focused on digital health regulation and AI implementation, where he gained a passion for responsible AI governance and adoption. He is passionate about connecting the entire healthcare sector to CHAI's work and providing a collaborative community that can help define how AI can help solve some of the health sector's most pressing issues. Brenton completed his undergraduate studies at Arizona State University, which we won't hold against him, and completed his JD and MHA at the University of Kentucky. I'm proud to announce Brenton as our speaker tonight. Brenton, the mic is yours, and thank you.
Yeah, thanks so much, Josh. Really, really appreciate y'all having me. And I will say I did get my Provo experience. I served my mission in Provo. So get your laughs out now is what I like to say. I was a Provo missionary and had an amazing time there, being in the Utah area. What I will say is this is the first call where I do have some of our founding members of CHAI here on the call in Providence and Sutter Health. So shout out to you all. I really appreciate your support of our organization and your involvement. So looking forward to engaging you as executive leaders, not necessarily AI leaders. So this is absolutely great. I'm going to share my screen here. I have a presentation. What I will say is this group is fairly small, and so if we want to make this more active dialogue as opposed to presentation, I'm fine with people jumping in and discussing. So don't feel shy. I've done this presentation now twice, and Britt, Lisa, Josh, and Daniel have already heard this. So please, I would be happy to make this a conversation if that's the way things go here. So let's get started. So I wanted to start out, to AI and beyond, to make kind of a cheesy intro here. But as I think about AI, it brings me back to my childhood and thinking of one of my favorite cartoons, the Toy Story. And there was this interesting scene at the beginning of the movie where Wood and Buzzy are having a dialogue, and Woody tells Buzz as he pops out and starts shooting stuff with his pretend laser, "Hey Buzz, you're a toy. You aren't the real Buzz Lightyear. You're an action figure." And so that scene has been distinctly in my mind since I was a kid. And so as I was thinking about this presentation, I was like, I think AI has the potential to be potentially compared to that. So, is AI just going to be a toy that we leverage, that's superficial, that's cheap and effective half the time, made of plastic, or is it going to be like the Lightyear in the new movie where he actually saves the day? And so the theme that I want to talk about during the remainder of the talk here is, technology is great, but at the end it's all about people. And so as leaders, that's your bread and butter. That's how we're trained as leaders, as administrators. And so I just want to make that note, first and foremost, that technology is not the key here. It's all about people, leadership, and how we solve problems. But first, I wanted to start out by defining artificial intelligence, because I think it's really helpful for us to kind of know what's out there, what the differences are, and what you can expect as you're, potentially looking at procuring different types of solutions. So traditional AI, I'll start with that. Traditional AI is just machine learning. It's been around for decades now. It came out of the military, I believe, in the late 60s. And so, military computers, they've all been using traditional machine learning to do prediction, to do, mass computing, and to perform singular tasks really effectively. So some examples of solutions that do this are, you take like sepsis prediction algorithms, you take disease prediction algorithms that have a simple mathematical equation. A human tells it the right answer. It trains on, hundreds of thousands, if not millions of data points, and then it quickly becomes more accurate and more consistent than humans. And so, there's those type of, algorithms in place today. Most of them are FDA cleared because they have some sort of imaging or, cardiovascular component to it. When you think about AI, and what people often think as AI is generally what we call generative AI. And so you think about large language models, ChatGPT, Grok, Llama, you name your favorite model. They're all based on the same technology. And essentially what this does is it takes machine learning puts it on steroids and adds a human layer of intelligence on top of it. And so instead of just predicting something and it having to be trained to do one singular thing, what a generative AI or a large language model can do is it'll take mass quantities of data, largely trained on the internet today. If you're thinking about traditional, ChatGPT or other large language models, it'll take that, it'll make a series of predictions based on historical data and then give you an output. So you ask it a question, it computes in its equation, in its black box, as we like to say, what it means, and then spits out an output. Sometimes hallucinating, making it up, which we all know is very interesting as you get those type of hallucinations. But oftentimes, it does a great job. It's very correct. Now the recent development, which has been in the last year, has been a concept called agentic AI. And so what agentic AI does is it essentially takes a large language model and it adds a layer of autonomy to it. So you think about a generative AI solution, a ChatGPT partnered with a software function that would allow it to make independent decisions, independent reasoning. And all of a sudden, you have something that is becoming the semblance of artificial intelligence. I think many people today are like, yeah, ChatGPT, maybe artificial intelligence, machine learning, maybe not. Well, when something can make an independent decision, independent of a human, I think we should start paying attention and probably start calling it artificial intelligence. But again, traditionally, all these three are captured under what we would consider artificial intelligence. And so what I want to do now is go over 6 kind of frontier use cases. And since this is ambulatory, I changed the use case that we had from the other day to really reflect what I think is probably even more important in the ambulatory space. But when you think about frontier AI use cases, the first one that comes to mind from a pure administrative standpoint is like AI coding automation. So this vendor would essentially, and we all know what a pain coding is in the healthcare context, especially in hospitals and health systems. We all know Medicaid's getting cut. Yeah, I was just meeting with the president of the Oklahoma Hospital Association today. $6.3 billion in lost revenue, and that's huge for a rural state. And so you think about something that could automatically code and what a benefit that would be, that could automatically bill patients, that could leverage this technology to do it. Now we're talking about something that's potentially really useful, and that could drive inherent value where humans necessarily can't. So you think about something that never sleeps, never eats, never has to take a break, and all of a sudden, it being able to code, take pertinent information, call up patients, automatically code encounters that could be a potentially great use case. Well, as an attorney, the alarm bells goes on off because you think about historically how the DOJ has acted for, false claims violations and other mechanisms. This could be potentially really risky. But the risk benefit rewards. I'm hearing of a lot of health systems that are like, we're going to wait on that whole coding thing because our attorneys aren't comfortable with us potentially getting sued for upcoding. And the other thing that I'm, really curious about is how conservatively are these applications trained, such that would it underbill so that it would not upcode or potentially, would it not code optimally such that it wouldn't be placing as much risk on a health system, but in the end, you're losing out on potential revenue. So, as you're thinking about, okay, there's this great AI solution. Think about the potential implications, use human reasoning, et cetera, et cetera. One of the other ones that I think is going to be really beneficial, that's probably a lot less risky, is OR optimization. And sometimes I question, there's this company that I was reading about, hey, we'll optimize your OR and we'll use all this AI. Well, sometimes what I think we should be looking at is, does this product actually use AI at all? And in this case, they specifically advertise machine learning. But when I talk to attorneys around the country that are in the steep of things, that are evaluating vendors every day, one of the first questions they ask, and actually how they're structuring their contracts today, are they're having to put a no AI clause in those contracts, and if the vendor violates that, that's when they bring up the use of AI. Or, they advertise AI, but there's actually no AI in the product at all. And so I think it's really interesting, in certain cases like this, where it's very dashboard heavy, where who knows what's going behind the scenes. You could have AI, you could not, but AI is being seen as a marketing tool today, often a marketing ploy by existing companies to get more of their products sold. So just something to consider. But again, OR optimization, effectively using your operating rooms on a daily basis based on historical data, translating that into scheduling, obviously a great use case. I wanted to get more into the clinical side of things. So, first and foremost, disease detection, one of the better ones that I mentioned earlier on the machine learning side. And this particular algorithm detects tuberculosis. And so in 2021, MIT researchers developed this algorithm, which essentially allows machine learning to go in and say, yes, this patient would identify positively as having a positive diagnosis of tuberculosis. And what's interesting about this is often actually used in lower resource countries. And so you think about Africa, you think about places where physicians don't necessarily have a level of expertise that we would have here in the States due to just, lack of resources. And then you think of the translation to rural healthcare where you have a lot of general practitioners, not a lot of specialists, et cetera, et cetera. You can really foresee where some of these disease protection algorithms, I mean, I think about my home state of Oklahoma, you think about diabetes, you think about cardiovascular disease. If you have an algorithm that can manage your population, especially if you are using value-based care, payment methods, and so forth, then you have something that's potentially really valuable that not only helps the patient, but helps you manage that patient effectively and use those dollars that you're allocated to treat effectively, treat even before there's issue, keep them out of the ED, et cetera, et cetera. So really good use of AI. I don't think it's utilized enough. I think a lot of people are still skeptical about clinical AI because of the inherent risks. People can get harmed if you misuse, if you misdiagnose. But again, I think this is going to be something that continues to move the ball forward. And then you think about, applications that are directly in the electronic health record. And so one of the biggest things that we've seen and a use case that we're focusing on at Chai is this whole Epic in-basket AI response feature, where we all know that physicians are often burdened because they're getting hundreds of messages per day in their EHR. It could be, it could be a really critical question. It could be nothing at all. But what this function does is it uses a generative AI model, probably a ChatGPT or another large language model, to read that patient message and then generate an automatic response, which allows a physician to go in or a nurse or whoever's assigned to answer those in-basket responses to go in and simply edit a response and send it off. So a great use case that optimizes physician and clinician time. And then when you think about some of the more meatier use cases that are getting more traction, I think about ambient scribes being first and foremost. And so I would imagine that a lot of you have already adopted this type of technology because your physicians have begged, pleaded, and clawed for it. But some things that we've heard are, hey, ambient scribes, great. It brings humanity back into my patient encounters. And so you think about physicians that have historically been burdened by significant amounts of paperwork, of electronic, of clicks, and now you have a function that allows them to face the patient, to touch them, to have normal human interaction, and that will bring their humanity back. And so these are really popular. We're seeing significant adoption of these, and we'll talk a little bit later about kind of the value proposition, return on investment, et cetera, et cetera. But again, really good use case, really something that I think is changing the industry. And then you go to the agentic side of things, which is more conversational AI, and you have a product in Hyro and a few others that will essentially have call center automation such that you could replace an entire call center if you really wanted to with AI agents that can proactively call, schedule appointments, do a number of functions, and do it just as well as humans. And oftentimes, that person on the other end of the line can't even tell that it's an AI agent because of how prolific they are. They talk just like a human. If you weren't listening, if you were, elderly, you wouldn't be able to tell. And so that begs the question of the whole ethics around this. So, what do we do when we have the choice to potentially replace an entire call center, save hundreds of thousands of dollars, and have a subscription model where you're paying an enterprise price for this, where you're paying maybe the price of a couple employees and you could replace hundreds. It's an interesting thing, but what I think is interesting is Intermountain is a big user of this technology, and so we had them at our recent event, and really the justification that they're giving for utilizing this type of tool is the concept that we all know, attrition. So jobs like call center jobs, front desk jobs, you name it, those have the highest attrition rates of most jobs in healthcare. And so when you think about the cost and the time it takes to recruit, to retain, to train, et cetera, what people are saying is, hey, we're going to reward our current employees that stay with us, that are true to their jobs, that want to work in the spaces, and we're going to reward them with technology that's going to augment and enhance the work that they're already doing. And so I think it's a really interesting and a great viewpoint of how the technology is advancing, because you think about things like computers and how they completely upended our lives. And when the computer came home with us and we were able to have a laptop or a desktop, and even in the office, millions of secretaries and scribes are replaced by a computer, because now an executive could type their own notes, they could do their own things, they could answer their own notes and emails. And the whole industry was up in shambles because of this, but now it's just the standard. And so as we think about change management, as we think about just like human nature, there is going to be, some bumps in the road. There is going to be some pushback. But the best organizations that I'm seeing today are saying, you know what, it's not about getting rid of people. It's about optimizing people to do things that matter most. And so if we can have a computer or a machine do something that we don't need humans to do today, why don't we train those people? Why don't we take those people, train them to be nurses, train them to be, managers, directors, whatever it might be, and place them in situations where they can actually help further the objectives of the organization. I put long term in quotes here because, as I think about where AI is going and where the potential it has to become, I don't necessarily think this is long term. This could happen in a matter of weeks for all I know. But where I think the industry is heading, and what I'm most excited about, is this whole concept of individualized AI. So you take me, you take my data, my preferences, my writing style, my knowledge, my expertise, and you take a large language model that can ingest that information and hopefully keep it proprietary. You never know with Sam Altman. He's infamous for not being able to answer a question about data privacy. But that's another fact of matter. And then you take an AI agent on top of that can act semi or fully autonomous. And you think about all the things, and I think about all the things I have to do on a daily basis. So draft contracts, make sure we're compliant with certain things, do general operations, do some administrative tasks. Now I think about something that could, potentially replace me and do all this autonomously or semi-autonomously. One, that would be a huge benefit to me, because then I have time to think about strategy and other important things. But also you think about, okay, what is my purpose? Where does my human input and action come in? What do I do? And so I think it's, as we see this evolve, I think it's going to be an interesting thing that we have to grapple with, is if a machine could do something as good as I can, and it's going to get there. I don't know that it's going to be arguing before the Supreme Court necessarily, but if it can do and streamline and answer my emails and do all that type of stuff, well, where does my human intellect and power come in? The other thing that I think we have to consider here, you see 6 vendors at the top that are dominating this space, and you got to wonder, what happens when 6 vendors control the entire market? They harness all the data. They have all the market share. They have all the power. Well, now we're starting to get into vendor lock-in, which is honestly a dangerous place to be. And I know a lot of chief AI officers, a lot of CIOs that are worried about this vendor lock-in, because at the end of the day, if you want the flexibility and you want to, march to the beat of your own drum and really drive the strategy that you want to have the best products, oftentimes these vendors make it really hard to integrate with certain solutions. And so then you're locked in to an Epic or to an Oracle Cerner or to a Microsoft suite. And research has shown time and time again, often those products are subpar. They're not the best, but people do it because it's the easiest way. And so in this, we think about, do we make the easy choice of vendor? Do we make the easy choice with us as individuals? And so I wanted to talk a little bit about the business case. And so I have up here a couple studies that I've seen in the news recently. One being around AI scribes. Again, this is getting all the attention. But the AMA comes out and says, gosh, ambient scribes are the best thing for physicians. Everyone should do it. So they save 15,000 hours, restore human, site of medicine, et cetera, et cetera. Great. But then you have an independent report here down at the bottom that would suggest that the findings are too early to tell for most of what we're seeing here. So financial mixed reaction, too early to draw conclusions. You think about, example metrics in the clinician sphere of attrition, burnout, the experience. Again, a couple positives there, but still a lot of mixed feedback, much like we have the EHR. So I think as executives, as we're calculating what's the return on investment, how do I justify the business case? How do I ensure that I'm, making the right decision? Oftentimes, the quantitative analysis that we often employ for these type of things is not going to be traditional, quantitative analysis. A lot of the times, executives are having to go more towards qualitative features to say, okay, is this good for the physicians? Is it reducing pajama time? Is it, ultimately benefiting them and reducing less, reducing their burden, et cetera, et cetera. If I can justify it with justify it like that and have, a minimal financial drawback, then it's probably worth it. And that doesn't even get into the peer pressure that's going on behind these that I'm hearing. But I think it's just really interesting. And then you have, one of the more important considerations that is both business and logistical around, there was a Summa Health took a Duke AI model. They said, hey, this is a great model. It works at Duke. We're going to plug that into our health system and watch it go. And what was interesting is that model epically failed, no pun intended, in Epic, but that model failed simply because it wasn't trained or tuned to Summa Health's data. And so what's interesting about AI is it's not a plug and play situation. It's not like a piece of software where, hey, I can, put it in a CD drive, install it on my hard drive, and it's going to work flawlessly like it does everywhere else. AI is local in nature. It requires one, complete accurate data, and two, depending on how that was trained and how it ingested that data and the demographics associated with that, if you are performing that on different demographics with different data points in different systems, it's going to act dramatically different. And so I think it's really important for executives to realize this and to consider that, hey, we can't just plug and play here. I can't, go out into the ether sphere, look at 20 different solutions that will solve all my problems and think that I can just go and implement those in a year's time frame. It's not going to work unless you have the underlying infrastructure and the proper governance around this. So I think it's just really important for us to consider those type of things as we look to make the business case. Now, some current challenges that I would say we're seeing, and I mentioned a few of these before, is one, the kind of scalability. What do you do? What is my strategy around platform versus point solutions? Point solutions are often better. They perform better. They have better user interfaces. They work better for the most part, more accurate, et cetera, et cetera. But then you have platforms which offer convenience, like I mentioned in the EHR. You think about trust, both in the technology as a whole, in the underlying technology, and then from the end users. Excuse me. And you think about, some nurse walkouts that we've been reading about across the country where nurses walk out because of use of AI. And I think it's a real issue. And then you think about, everyone being worried about, am I going to get replaced with AI and with software? Well, a lot of this boils down to culture, to people, to the effectiveness of leadership, and we'll get to that a little bit later. And then you think about sufficient data. And so with AI, good data equals good AI, bad data equals bad AI. And so, in my opinion, before an organization even considers AI, you need to do a mapping of your data, mapping of your organization, and consider, okay, is my data flowing into a centralized place, or is my data flowing into places that it can actually be used? Is my CIO leveraging that data appropriately such that we can plug in an algorithm and it's going to have that data flow into it correctly, consistently, objectively, and without incident? I think one of the most important things is when you look at the legal and policy landscape today, one of the more interesting things is this current administration, they're not going to give you anything. They're a wait and see, we're going to watch this and watch how it plays out, which isn't bad necessarily, but traditionally in healthcare, we operate under very specific guardrails and guidelines. And so when a risk department or legal department does not have the government telling them what to do every step of the way, and instead we have Biden era policies that may or may not be enforced today, and then you have no real guidance from the government, a lot of people feel stuck. I see a lot of academic, mature organizations that can do this really well getting stuck and not progressing forward simply because they are afraid of potential implications. And so I think it's a real issue. I think it's a real current challenge, but I think it's something that we can overcome as we look to frameworks, hopefully, coming from China and others, to set you up for success in that. I mentioned vendor lock-in. Again, I think governance being key here, and then obviously leadership. One of the things I'm more proud of here at the coalition is we just signed a recent partnership with the Joint Commission to join forces and develop responsible AI playbooks that your organizations can take and adopt and start to feel good about your use of AI. And so one of the things that we're going to do around that is we're going to offer a voluntary certification, again, not accreditation, not your conditions of participation, but a certification that you can do to check against, hey, do I want to see how I'm doing with AI and with the controls, Chai recommends. So something that we're doing to combat the challenges that I've enumerated here. But again, these challenges are going to persist regardless. And so how do you transform healthcare with AI? Well, one book came to mind, and from the infamous Brit, Patients Come Second, where it's really not about the technology at all. And so one of the thoughts or quotes that I came up with that the technology is only going to be as good as the organizations using it. And so I've seen, organizations here in the Midwest that will adopt an AI tool for nurses, again, one of the hardest stakeholder groups that we have in healthcare. For nurses, they've got 100% adoption across multiple facilities in a matter of weeks because they took the time to do mission vision alignment. They took the time to go on the floors to talk to nurses to get their opinions. And they took the time to do the proper training such that when they did that rollout, it was as seamless as ever. And then you have other organizations which, maybe didn't do as good a job of that, and they're getting walkouts, unfortunately. And so, again, AI is the key about this, and as leaders, this, that the key to success in this is make sure we're managing people, managing up, and having success in those relationships. And so when we think about small and simple things, I think a proprietary formula, and I'm from Oklahoma, so I got to celebrate an NBA championship because who knows when that's going to come next. But I think about, the Thunder and what they did as they put together a championship run. I thought about the data, that historical data, all those times they went to the Western Conference Finals, all the analytics that now the NBA is doing. I think about a healthy culture. I love the Thunder because one, they're, I think, the youngest team in the NBA, if I'm not mistaken. And two, when they go to interview post game, they all do it together as an entire team, and they approach the local reporters before they approach ESPN or TNT or any of the national networks. So it just goes to show that these guys are not only bought into their team, but they're bought into their city, the culture, the local aspect of that, which I think is really cool in a day where everything's about self-promotion, et cetera, et cetera. And then you think about Sam Presti, who's the GM of the Thunder, and all the foundational investments he did, the trades he made, the sacrifice that he made for a couple of years. I think 2 years ago they won 20 games, and this year they won 68. And he had the most draft picks of any GM there. And now they have the best salary cap, and they're able to make strategic moves. And so I think about that. I think the same type of formula can be really used for AI. And I'm going to go over 6 steps that kind of enumerate this, but as a whole, small and simple things that you can do. You think about culture, investments, and good data. that leads to a championship-like atmosphere as you look to do really anything, but especially technology, procurement, and strategy. So as I mentioned, I think there's 6 simple things that we can do as healthcare leaders as we think about our AI roadmap. And oftentimes, I find that leaders skip to step number 6 and say, hey, when and what do I buy? I want the latest and greatest. Let me go and buy something that I think is going to solve a problem. Where instead, we should be focusing on, as we all know in traditional, leadership theory, going and seeing, observing, figuring out problem identification, and then working our way through this such that we know exactly the problem that we're solving and what and when to buy. And so along that way, I think there's a lot of things that we can do in terms of cultural assessment and mission alignment. So are my physicians still struggling with paper charting, with wanting to go back? Do I have a relatively senior physician group? Well, if that's the case, then you may have to go to the drawing board and say, okay, how do we strategically put the right AI solutions in place such that they could be adopted? Or is, simply replacing humans with AI against my organizational mission? Am I faith-based? Am I the pillar of the community that everyone sees? Is my PR going to go bad if I start adopting AI solutions? It's really something that we should be considering. And then third, kind of the sandwich in between these all is how good is my data? I mentioned that before. Data is a new oil, and so a lot of organizations I don't think have really figured out the value and the value of their data. And so I would say is if you're ever trying to buy a solution, they want your data, don't let them have it. They need to pay for it, and you need to get something in return, or as we say in contracts, consideration for that. And then, fourth, again, what foundational investments do I need to make? 5, making sure I can actually govern this. When you look at one of the most important parts of governance, I know it's a sunk cost. That's how people look at attorneys too. But when you look at attorneys and you look at the money you're spending on them, and then you say, okay, what are they doing? I think of the same thing with governance around AI. In the end, it's there to protect you. It's there to de-risk your operations. And so, making sure that you can monitor this real time, that you know how it's performing, that which stakeholder groups are not being disadvantaged. Because you can imagine, equal protection clauses of the Constitution being brought up because you used an AI solution that discriminated on certain subsets of your patient demographics. And so super important that we ensure responsible use. And then again, when and what do I buy? So I want to end with a scripture that came to mind as I was putting this presentation together in the Doctrine and Covenants. And so it says, "Verily I say, men should be anxiously engaged in a good cause and do many things of their own free will and bring to pass much righteousness. For the power is in them, wherein they are agents unto themselves, and inasmuch as men do good, they shall in no ways lose their reward." So in a world of increasing AI agents, in a world where oftentimes we don't feel like we are agents unto our own selves, I want to remind us that in the end, it's our Savior, it's our country, it's the humanity that we have that is going to define us and really help us succeed in a world that's driven by technology. So thanks so much for having me, and I think we're going to do some questions now.
How many of you thought that was fascinating? How many are using AI in some application in their current area of responsibility? I mean, I think it's fascinating because he outlines some key points. So what are some of the takeaways? Observations or questions? Tim, did we get your microphone back on? Or are you still?
Oh, can you hear me now?
Yeah, there you are. There you are.
Yeah, I only have 6. Apparently, I need AI to figure out how to help me get my microphone set. We use I use AI in a very limited sense right now. I thought this was fascinating. Thank you very much, Brenton. That was very informative. Because we've been attending, you hear about AI and its use in terms of licensing and trademark and intellectual property, but in terms of how we're going to apply it in business, I think it's still on the frontier side. I think we're a little tentative in that in my business. And I work for United Healthcare, in the provider contracting legal side. So
you don't think you guys are going to use it?
I think they will. I don't know. how I
United
think
Healthcare uses it. They're also one of our members, and I can say that you all are using it. Whether you choose to disclose that to the public,
well, I may not be privy to that information, so I can't
Actually,
tell you.
Tim is a robot, so I don't know if you knew that. It's actually
Yeah, did you
an
know?
AI.
So,
Michael, what's your take?
Yeah, so I do have a question for you, Brenton. So you showed up a slide, had a bunch of AI scribes on there. I think altogether there was about 40 different companies.
Yeah.
And just thinking about the cost, initial cost to kind of, sign a deal, ink something and then get it going. The startup cost and all of that can be pretty
Huge.
big, right? It can be almost insurmountable for small systems. And 5 years from now, how many of those 40 some odd companies are actually going to exist? And I think that's where, as I think about implementing new technology, I get a little bit nervous because you talk about the vendor lock-in, right? I mean, when it comes to EHR, nobody wants to do a different company besides Cerner or Epic, right? I mean, if they do, they're looking, how do I get eventually onto Epic or Cerner? With all these different scribe companies, how do we decide which one to go to? And I'm sure, especially now, that some of them, I don't want to call them, that there's probably, let's just put it this way. I'm sure there are some that have business practices that are not completely ethical, right? In terms of data, what you do with that data and all of that. So, AI can be a really scary thing with how much data it can take. So any thoughts about how to go about this?
But let me just push back a little bit because I think things that are simple that we saw. Remember when all the billing went and you've got like 5,000 medical practice billing companies? I think something as simple as scheduling or communicating with patients, I think it's a natural. And I don't think you need a big investment on that, but that's my take on it. Brendan, the question's to you. What are your thoughts?
Yeah, so we have a theory that so we led last year with an initiative called an AI nutrition label. And we were getting this question quite a bit from our members saying like, how do I distinguish between, hundreds, if not, dozens of vendors? And the way we're pushing, we do a number of policy work as well. And so we're actually engaged in your home state of California. I was just on the phone with someone from the assembly today. And one of the things that we are really interested in seeing is mandated transparency. And so I'll put this in the chat. I don't think we have time to go in depth today, but our nutrition label is getting a lot of movement in it because it provides a standard template to compare solutions against. And so what I think needs to happen is, and where we're seeing the most push is customers need to stand up for themselves and say, you need to provide me this information before we even have another conversation. And I think the more that we can do that as potential customers band together and say, we're not going to take marketing materials anymore. You need to start producing objective analyses. You need to start producing more data for us to actually understand how your solution is going to be used, what the purpose is, what the risks are, et cetera, et cetera. Until we as an industry, and especially as end users do that, we're just going to continue to be dominated by, the tactful salesmen that each of these companies have. And
Yeah.
so for
Yeah.
us, that's how you start. It doesn't solve everything, but we're also putting together an outcomes registry. And so in a world absent of, historical data on these functionalities, you have to band together and actually crowdsource data such that, hey, X number of systems are using this product. This is their experience. Maybe I should actually consider this. And so those are two ways that we're hoping to get around this, adoption curve right now. But again, it's going to be really challenging. I don't think it's the perfect solution, but just something that we're trying to do to help in the meantime.
Other thoughts?
So, Brenton, I've got a question for you, and it's more on the patient-centric side. So, healthcare, we're all driving towards what new inventive ways can we kind of master ourselves to be more efficient, right? What in the AI space is being created to kind of make the life of the patient easier, whether it's making the patient experience either easier or making the patient's life easier post working through the healthcare experience. I haven't heard a lot in that space. Is there any kind of insight that you have to kind of share?
Yeah, I think one of the reasons you're not hearing about it enough is because those types of technologies are likely to be considered software as a medical device, which would mean they would have to be approved by the FDA. Most of those functions are actually going to be generative AI. The FDA cannot approve a generative AI functionality. And so what's interesting is today the cost to go through the FDA for a startup is between $2 and $5 million. And that's going to take most of your seed funding and your Series A if you're not, getting a ton of money. And
Yeah.
so what's interesting is most companies today are opting to do more like, non-clinical decision making, more administrative functions in an era where we don't know what FDA is going to do simply because of that. What I will say though is there are a number of groups trying to create what we call kind of general advice chatbots that could interface with your front website, for example, that could point you in the right direction for things. But in terms of where I think we're going to head, but maybe not yet, in terms of giving like preliminary clinical advice or anything, I think the risks are a little bit too, the risk outweigh the potential benefits right now. And so that's where I think that's going to land. But I like where your head's going because that will happen. I know Mayo, was developing a Dr. Mayo type of thing. So I think organizations are thinking about it. It's just when those are going to be rolled out, I'm not sure.
Okay, so quick follow-up to that. Since, the healthcare space is so eager to get their hands on all these products, what have you
Yeah.
seen from where you're sitting from the patient side? How eager or not eager are they from the AI to enter into healthcare or into their sphere, like into their space in general?
Yeah, so we work with about 10 to 15 different patient advocacy organizations, and they, I actually have a meeting scheduled next week with them. And what they told me is, hey, we want to figure out a way to get ChatGPT to leverage our data to give me better insights into my medical history. So I think patients are ecstatic about this, especially patients with chronic conditions that have yet to be solved. So you think about ALS, you think about some of the more complex diseases, you think about breast cancer, and people want answers. Well, they're looking to AI to get answers. And most patients today, they're going to ask AI the question and then compare that against their doctor. We've probably all done this at some point. I'm guilty of it. But a doctor tells me something, and I'm like, I'm gonna ask ChatGPT and compare against that. And if they're at odds, it leaves us a little confused and asking more questions. So but we are really seeing an increased demand for this, and I think it's going to be even more apparent as the technology gets better.
This has been a great night. I don't know about you, but I found great value, Brenton. I can't thank you enough for your expertise and your commitment. I think you would welcome any calls offline. I
Yeah.
think you need to watch Chai and see where they're going with this. I'm on their advisory committee, and it's fascinating to hear people from faith-based healthcare organizations and upper education struggling with this. I think this is more than the introduction of Google, right? We all remember and an electronic medical record. Remember one of those? I think it's a lot different, and I think we need to keep our eyes on it, and then share one with another what our experiences have been. So, Josh,
Well, thank you everyone for attending tonight. We really appreciate you being here, your inputs, and Brenton, thank you again for all of your insights tonight and your speaking. I thought it was extremely informative. Once again, everyone, we have our conference coming up in October. Please be in attendance. We'd love to see you all participate and be there. If you have any questions, please reach out to me, reach out to Britt, reach out to Lisa, or anybody else from our BYU healthcare team. We'd love to communicate with you and make sure you have all the information you need to push BYU healthcare leadership. We appreciate you all. Thank you so much. Have a wonderful night.
thanks everyone.
Thanks, Phil.
Sure.
Thank you.
That was great. Really appreciate it. Hey, Josh, what do you think?
That was great. Yeah,
On with you.
Brenton's, great presentation, good information. I wish we had more people, but
Yeah, I'm just confused by that because nurse leadership was low and also hospitals was low. And maybe it's the time of the year? It's
it's hard. A lot of people are traveling. I see just low, even at my local ACHE events, we're low in stuff. People are just busy and stuff like that.
Lisa,
But
so we're gonna have the October event, and then we'll do one more in January, February. And if we don't see a significant spike, then I think we need to consolidate them together.
I think last year we announced this at it, and then we had a lot of interest post the October meeting.
Yeah.
I think now that we've got it up and running, we've done a couple. I think we do the October, our big leadership conference. We drum
Yeah.
up a lot of interest in it. We get, we do the networking event there to actually tell people this isn't running, it's up and running. We've had sessions, and then we push it, say, please attend. We want you guys to, network in these things. I think we promote it really heavy at this next conference.
Do we do it then in November as opposed to wait until January?
I would, just because I think post the October conference or our healthcare meeting,
There's
people
buzz.
are really excited. Yeah. And so to wait till January after the holidays, I think it loses a lot of the excitement.
What do you think?
Shannon's pushing for that as well. She wanted an October or November meeting. And one thing that we could think about too is that in January and February, we had students invited. So it did boost our numbers that way. I'm curious to think, to find out now how your reaction to that. Like, do we prefer having the students? Do we enjoy it being more the professional side?
I think you get heads, but I don't know. What do you think,
The
Jeff?
quality changes, the discussion changes a bit.
So there's two components. I'd always have one with students and then one without, because I think our vision is always to get the leaders with the students. So to exclude them entirely throughout the year is not what we're about, right? We want to get them blended. So I think we do one and then the other. So this one is fine to not have students because it allows us to have very targeted conversations, which is good. I think the one in October, I think we should have students because the students will be energized from the conference. We theoretically, we will have more in attendance to get them connected, and they will have already connected. I think it's good. I think one of the year should have students and then one shouldn't.
Lisa,
My suggestion